Welcome everyone here to the Royal Hospital for Women. It's our only public female-centric hospital in all of New South Wales. A very warm welcome here tonight. I do want to acknowledge that we're meeting on the lands of the Gadigal and the Bidjigal people and pay my respects to elders past, present and emerging. So we might just kick it off. Microphone here. 1 minute elevator pitch. What do you do?
So my name's Jason Chow. I'm a obstetrician gynaecologist, but I'm also a pain specialist. I'm the clinical lead of the Royal Pain Service, which is the chronic pain service here at this hospital. And I have an interest in looking after and advocating for women who suffer persistent pain. Marjorie, thank you for putting this together. And this is great advocacy and the foundation for this today. But we were just talking before that this is such a common area, but it's because it's presumed common, it's presumed to be normal, but it obviously doesn't have to be normal. And I think we can always do better.
Hi, my name's Amy Lee. I'm a clinical psychologist and I work in the chronic pelvic pain service here at the Royal Women's. My special interests and expertise are in treating eating disorders and chronic pelvic pain, and also adjustment to chronic illness. So I've completed a PhD looking at mindfulness for people with MS, and I'm really interested in helping women, come to terms with chronic pelvic pain and manage that.
Hi everyone, my name's Therese. I'm the nurse unit manager of the gynaecology outpatients clinic here at the Royal Hospital for Women. This is where the Royal Pain Service runs out of, so I help with the coordination of patient care with that.
Hi everyone, I'm Kimia. I'm one of the senior physios here at the Royal. I am also a titled continence and women's health physio, which just basically means I've just done a little bit more study. I have been very lucky to be part of the pain service for the last close to 18 months, and it's one of the hats that I hold along with the Urogynae and men's health services that we run, but it does hold a very special place in my heart working along this team here.
Thank you. Now, tonight we're trying to cover as much as humanly possible in 45 minutes. We're going to be covering the 4 life stages of adolescence, perimenopause, peripartum, falling pregnant and pregnancy. We also want to be really covering the themes of making sure that women feel safe and believed, individualised care, empowering women to guided treatment. Jason, what is meant when we describe persistent pain in women, and how commonly are women affected by chronic pain?
So Marjorie, chronic pain is actually quite common for women. So chronic pelvic pain can occur in anywhere between 15 to 25% of women. So up to a quarter of Australian women can have persistent pelvic pain. Now, a lot of that group you will find, and I know from some of the audience members who've come tonight, have talked about endometriosis, and that is one of the more common causes. 1 in 7 women in our last survey of Australian women who are younger than 45 suffer endometriosis, but there's a big proportion of those patients who have chronic pain that don't have endometriosis, or that the endometriosis alone doesn't just explain that. So this is actually bigger than just that area, and includes women who might have period pain, but quite debilitating. It might be women who've had many surgeries and had pain, women who, for example, have had surgeries, have given birth, sexual pain, and also pain that occurs in menopause. We might talk about this a little bit later as well, but nearly half of chronic pain conditions are more common in women than in men overall. And I think overall, we also know that over time, women's pain has been less validated and less recognised. That's historically, and some of that's biological, some of that's also social and cultural. But we also know from a research point of view that a lot of the models, even in the lab, tend to be, so even rat and mouse studies, don't distinguish sort of male and female rats. A lot of it just tends to be male population. So they don't even think about sex and gender-based issues when we do the research, and that's been a historical bias as well. So very common. Anyone who's had pain for most days of a week for 3 to 6 months is considered to have chronic pelvic pain of any cause.
girls present with pain sometimes from when they first get their period. Now, we've received feedback from mums in the audience that are here today. What advice can you give to girls and their families about managing their pain?
So I think the first thing is that everyone's pain is their own pain. And again, commonly, 9 out of 10 girls and women might get period pain. So we consider that to be common, but the degree that you suffer or it affects you is going to be individual. And so we need to individualize how we look after and the needs that are met from that girl in that family. There may come with that different backgrounds about how you're brought up with understanding around your periods. It might come from the background of the family, from your friends, from the school, and they might have different experiences as well. We also know that having pain that is repeated from a younger age can have effects later in your life, not just from a period point of view, not just from making those diagnoses, but also how that will affect your pain nervous system and your mental health. So those long-term downstream effects can change how your pain nervous system and your body changes as you grow up as an adult.
Do you have any thoughts?
I would say if you're a young girl or a teenager and you are having pain, it's really important for families, parents to speak openly about things like having your period, make those conversations feeling comfortable, and acknowledge what your daughter's experiencing. Listen carefully and give them space to talk about what their symptoms are. And I think what you can do is start building start helping your daughter build a bit of a toolbox, I would say, of strategies that can help them manage their pain. So looking at things like having a list of maybe distraction techniques or distraction activities, having a list of things that you can do that are soothing that will help you, having a list of things that are relaxing that could be beneficial. The key is to really help your child start understanding what's going on with your body, drawing connections, trying to find a pattern between their symptoms and what's happening for them day to day. Tracking apps can be helpful as well. Things like the Flow app or the Health app on the iPhone are a really helpful way of starting to understand if there's a pattern going on, because all those things will be really helpful as well when you do go to your doctor.
So women present with pain from many walks in life. Therese, as a nurse manager of gynaecology outpatients, what type of stories do you hear?
I guess just reiterating what Jason said previously. So the type of stories that we often see here at the Gynaecology Outpatients Clinic could be patients experiencing painful periods, women who've had pain after surgery or giving birth, also women going through menopause and just having pain during sexual intercourse, and even a patient who's just recently been diagnosed with endometriosis. Another thing that we may see is that some of these women have already been seeing doctors, health professionals, or other specialists for quite a long time before they have found the treatment or care that they're looking for.
Can you give, I don't know if people know, but if anyone can answer this, the average length of diagnosis for some of these?
It depends on the condition, but I can name a couple of them. So for endometriosis, it can be years to make the diagnosis, and often you've seen several specialists before that occurs. There are some conditions. So there's a condition which some women have where they have a pain in the genital region, so pain in the vulva, vagina, anus, perineum, and that nerve called pudendal nerve pain is not common. We think it might be in some cases only 1 in 1,000, 5 in 1,000. Women may suffer, but most women will take 2+ years before they see someone around that. We know that this is an Australian study, women who have new sexual pain after they have a baby, up to half of women at 6 months will have sexual pain, And by a year, that's a quarter. And that is still a quarter at 18 months. So which means that the women who don't get better from sexual pain by the end of the year are still got that pain. And these are big numbers. So it take that duration is quite long.
We're sort of touching into another question and sort of topic, which is women often describe feeling unheard in their pain journey. And you can imagine why that is when it takes so long to diagnose and to treat. I guess getting to the root of it, why is that?
Sadly, that's true, that the journey to diagnosis with chronic pelvic pain is really a long and arduous and stressful one. There are lots of challenges and barriers that women go through before they even pitch up at their doctor's office. There are, you've got cultural and societal beliefs that women's pain is normal and should be accepted, that pain is part of becoming or being a woman. There's taboo issues in some cultures and religions that we shouldn't talk about the pain. We should feel embarrassed about it. And it's not something to be discussed. And that you should just, carry on, I guess. Some women even sadly meet like medical beliefs out there that severe pelvic pain is normal in women. And there's stigma as well, I think. There's social stigma, and women worry about talking about it in the workplace. And as a result, they're often isolated and ostracized. Sometimes they even are discriminated against or feel worried that they're going to be discriminated against because of their pain. And so it really takes a lot of courage to actually come to your doctor in the first place. And unfortunately, part of the journey involves, for many women, lots of doctor's appointments, investigations, sometimes procedures. And women often leave those appointments having more questions than they have answers to, or they feel that they still don't actually quite have an explanation as to what is going on with their bodies and why they are actually having that pelvic pain. Sometimes it's due to treatment failures, but there's a lot of disappointment that comes along with that. And they often feel that they are getting some part of the picture, but not actually fully understanding what's happening. And they often come to our clinic very distressed and distraught, having been seeing a lot of specialists and feeling very overwhelmed with like what to do about it.
I just want to add to this conversation in terms of just completely agreeing with what Amy Lee was saying in terms of a lot of stigma around women's health. But what I would normally say to some patients is every one of you here who have attended this session is playing a massive part in breaking down these barriers that women face by just coming here and, trying to gain some information and education around pain with women and having conversations, whether, it's over coffee talk or bathroom talk. You're breaking down those barriers that women face because it's currently still a massive issue for women to face, to even, they feel a lot of shame around their healthcare issues. So as nurses, we get a lot of, those conversations from patients, and they go, I don't know anyone else who's experiencing this, but if there's something that women can do well, it's talking about our experiences and sharing it, because you'll be very surprised to see someone else also going through that same experience that you have.
Yeah.
I think Therese also touched beautifully on this around sharing your experiences and being open to your own vulnerabilities, but those of your friends, your colleagues, a stranger in the street. I think it's also really important that these issues are raised to the men in our lives as well. And it's really nice to see a few males in the audience today. So I think having those conversations and having that sort of transparency between genders is also really important for those that do come across the workplace or interact in different environments with those of the other gender.
So what treatments are available?
The treatments are broad, and I think traditionally the way that we look at pain is to find a cause and often a lot of women's health is looked after by broader community, but by GPs and gynecologists from a medical point of view. And a lot of the gynecology training, and this is not a criticism, this is the way it is surgically based. So a lot of our courses are about finding a cause and basically doing surgery for that cause. It's a very limited way to look at pain. We know when we think about a pain for a woman, and from everything that everyone's been talking about today, that it's not just about finding whether it's endometriosis or finding that nerve that's involved and then relieving it from that point of view. We're looking at your whole body. We're looking at you as a whole person and really, looking at it not just from that biomedical model, but also from your well-being. Yes, no, thank you. So that true, we call that biopsychosocial, or the other way around, socio-psycho-biomedical model, and looking at that person as a whole. So the treatments then need to be broad. Yes, we do need to identify those specific causes, understand that and treat those specifically. And so those involve those medical treatments. I think the first one is no matter what the cause is, you validate and you treat that pain. And that treatment doesn't just have to be medication-based. There is certainly a role for some medications with pain, but a lot of the traditional medications for these conditions don't hit the notes or don't really address those broader pain nervous system changes that a whole body, brain, spinal cord, not just where you feel the pain in that region. It is also about understanding the distress and the effects that cause in that person. So it's listening to those stories, but also looking at how do you learn skills to advocate and self-manage? How do you learn skills to communicate, for example, with your employer or your parents or your children, your daughters, and in terms of how do you manage that? It's looking at non-surgical, non-medication-based ways to manage things. So physical therapy, alternative therapies have a big role to play around this. So that range of treatments, yes, tend to be tailored to understanding those specific conditions. Again, it's not just endometriosis, it's not just those things, but looking for all these other things we don't traditionally look at: muscular, nerve pain, vulvar skin conditions, but also looking at the whole person.
From a psychology perspective?
Look, I think most women, when they come to sit with me in the clinic, feel really on the defensive and are quite curious to know why they are seeing me in the first place. And it's really important that my messaging to them is that your pain is real and we believe you. We know that you're suffering. And the role of a psychologist is simply to help you manage your pain better and help reduce the impact of that pain on your quality of life. And there are lots of different strategies that psychologists can teach you if you have chronic pelvic pain that look at that broader picture, that holistic model of helping you with all the things that might be perpetuating the pain, things like poor sleep. A lot of people with pelvic pain have very poor mood, anxiety, and things like that. So there's actually a lot of scope to work with the psychologist from a holistic point of view. But it's really important, I suppose, to be really sensitive to that patient's journey and where they've come from, because often they've had different experiences where they've been made to feel that their pain isn't real, or they've been told, look, there's nothing wrong with you, you should see a counsellor. And that really puts us on the back foot when we start off. So, yeah.
What about Therese, from a nursing hospital context?
I guess from a nursing hospital context, to bring it sort of all together, from a nursing point of view anyway, we're often the middle, I guess, coordinating the care between, I guess, all of these lovely medical and allied health that are quite involved in that pain process. But I think the main thing is, like, if we're the ones who are always in the clinic. So if there's any issues or concerns, we will take on board what someone is saying, and we will advocate for you. So please make sure that even though the doctors or the physios, they might not be as accessible, but there is people that you can turn to and talk to if you need any help or treatment.
And a physio?
So from a physio perspective, I think this is a component that often you think about physio and you go, oh yeah, I go to my physio to check, like, for my lower back pain or my knee pain, or I've rolled my ankle. But physios do play a really significant role, particularly in chronic pelvic pain management. I think the biggest key is accessing a physio for chronic pelvic pain. You need to make sure you're accessing someone that is or has done further studies or exploration in pelvic pain. And the reason for that is it's the validation process, because they'll have the right language and they'll have the right skills and toolkit to be able to provide you with some strategies on managing that pain. Some things to expect when you see a pelvic pain physio, a chronic pelvic pain physio is firstly, Jason touched on this beautifully, but is that it's about being able to understand the pain and being able to explain it to you in a way that is easy to understand, easy to digest, and breaking it up into ways about how you can then manage it in simple steps on a day-to-day basis. We look at you from a head to toe perspective. So we look at how you're moving, how you're sitting, how you're walking, and things that might be impacting your day to day. So how you can get around with work, with exercise, with activities. But then we also bring it to a more pelvic specific focus. And I mean, I'll disclaimer that with saying that obviously just because the pain is in that area doesn't mean that it's the root cause. But we do have skill set in understanding around bladder and bowel function and how that might interplay into the pain experience, your pelvic floor muscle function and how that might also be contributing to the pain. And then bringing that all together, we look at day to day, and a little bit kind of crosses over to some of the things that Amy Lee touched on around how you manage life, pacing activities, those difficult conversations, and then some of those coping strategies or all the different kind of mindfulness components that you can bring into it. And all together, putting it into a nice little package.
Another important life stage for some women is having their own families. Now, it is said that pain often goes away during pregnancy. Is this true?
Not always. I think a lot of this message actually comes from an endometriosis sort of story. And actually, when you look back at where this came from, it came from a statement that a gynecologist made in the early 1900s without a particular study. And the thinking behind it is that if your pain is hormonally or cycle dependent, when you're pregnant, there's more cycle stability. And often in the first few months when you start breastfeeding, there's some suppression of your estrogen. So that cycle stability may make things quiescent. But if you've got a hormone-based condition, it will only be quiescent during that time. It doesn't mean it will go away. And that includes for endometriosis. But that includes for a lot of other conditions. And so these other conditions that get melded into that thinking with endometriosis may not actually change in pregnancy. Now, that doesn't mean you have to suffer during pregnancy, but it's about being aware and then managing that. A lot of women choose to stop their treatments during pregnancy for fear of harming their baby. But actually, a lot of treatments can be safe, or can be safely transitioned with planning in the months or in the first a month of pregnancy. Ideally, we'd love to plan these things, but these things can be addressed. It's not that we have to withdraw everything and suffer for the sake of your baby. So some conditions certainly will stabilize. A lot of conditions don't necessarily go away altogether, but yes, we can do better.
Do you have anything to add?
So around the pregnancy or planning to conceive and the postpartum picture, as Jason mentioned, it's not necessarily that there is a trajectory that will follow when you do fall pregnant, or that there's a clear equation, but rather the fact that pregnancy is a journey for anyone, even without the chronic pain picture, and it can unfold in many different ways. And so that pre-planning and then the handling of whatever is to come, whether it's from a musculoskeletal nature. So obviously the most obvious part is with pregnancy, there are changes to the body, and that can mean that you have different pains that come about. And that's something that your physiotherapist can work really closely with. And Similarly, same with bladder and bowel, there is greater load onto that pelvic floor. And so the most comforting part around the pregnancy picture is that we have so much good evidence on pelvic floor muscle training, on exercise, and the ways it can actually both optimize the pregnancy picture, but optimize your birth experience, and then the postpartum picture. And often we find with those that do have chronic pain, they're some of the best patients when they're in that pregnancy piece, because you've had to go through so much of that already, and the process of implementing the exercises or the lifestyle changes just comes naturally, and it actually allows for like a beautiful like transition into another life stage for these women.
Stick on you for a minute because I've got another question for you. For women suffering pain, having sex can be challenging. How do women seek help around this?
Yeah, it's a big one. Having sexual pain can be a silo-based condition, or it can be another component of the chronic pelvic pain picture. Sexual pain can be due to a number of reasons. Very similar to chronic pain, it can be, it might be in concern related to intercourse itself, but the way or the management can be multifactorial or multifaceted. So the biggest key is understanding some of the drivers of the sexual pain. So as physiotherapists, we look at whether the pain is of a nervous system nature, of a connective tissue or skin related nature, a muscular, skeletal or muscular related nature, and we can then provide some interventions to manage that a bit more specifically. But that's in conjunction. It can sometimes be a combination of some of those things. I think particularly we spoke about sexual pain in the postpartum piece. It's also a huge component in the perimenopause to menopause piece as well, and with that transition in that life stage. So there are definitely differing factors that are more contributing in each of those life stages. And yeah, so we work with those components to manage that.
Beat me to a little bit of the punchline. The next thing we wanted to be talking about was perimenopause and menopause. Sexual pain is often discussed in menopause, and for some women can be and have a huge impact on their well-being and their relationships. What happens with or to women's pain during menopause? And I guess this is a question that I'm going to ask all of you.
So I guess menopause is, again, like it's today's topic is pain and chronic pelvic pain, but you know, menopause is it's significant life transition experience, and pain itself is so complex, and then you're going through this huge change from a hormonal perspective, which I'm sure some of the other members of the panel will be able to explain a lot better than I will. But essentially, it's the interpretation and the management during those fluctuations and those changes during that stage that you really, really can make it quite difficult and isolating in those circumstances. So definitely there are ways that we can manage it and assist in the pain picture piece, but it comes down to like seeking the help at the right time.
I think obviously the change in hormones is a big feature around this, and I think the narrative over the last 20 years with some big studies that occurred in the early 2000s changed how we thought about hormones, but not necessarily thinking about the quality of life issues that women face. So I think there's been a lot of fear around using about looking at things from a hormonal point of view. It's also understanding that it's that these hormonal changes affect women more broadly. So you could end up with things like joint pain, changes in sleep, changes in mood, which will affect also if you have a baseline persistent pain condition. So not just from a pelvic point of view, this can adversely affect women who have migraines or headaches, or who have other joint-based pain issues, rheumatological-based issues as well. With those changes, you've talked about sexual health, and obviously the hormonal and skin changes and the things that come with that are a part of that. But also with the life stage, there's changes in relationships, and there's changes in mood and libido. All these factors have an impact. So when someone might come to see traditionally a doctor, they may only look at the specific place where you describe your pain in your body, And in a 10-minute or 15-minute consult, they may not ask or get to know all about these other things that are going on in your life. And I think spending that time, and you may not get that all in one visit, but to be able to do that with that built relationship with that healthcare provider is what we hope to do. But even more than that is actually understanding those different pieces and giving you as the person that information to be able to help coordinate that was really what the idea would be. So to be able to take that on board and be able to find those different components and be understood about them.
Therese, from a nursing perspective, do you have anything to add around that multidisciplinary approach? And I guess that's really what is unique and special about this pain clinic.
I guess from a nursing perspective, it's just being able to, I guess, inform the patient of what's available. So I think when a patient comes in, what the nurses are often involved in is just explaining what the consult at the Royal Pain Clinic will be. So it could be you may see a medical professional such as Dr. Chung, you may see a psychologist, and you also will see a physiotherapist. So it's just providing, I think a lot of people when they come into a hospital, they are under the impression they will only see a medical officer, but it's just to also open up the patient's knowledge that there are other resources that can be provided here to help manage their pain.
Last question before we open up to the floor for each of you. What is your key message for women and girls who suffer pain and, I guess, the resources available at the Royal? You're each going to answer it.
Look, I would say that really simply, there actually are things that you can do to manage your pain. You aren't doomed to a life of misery. There are actually really good evidence-based strategies that you can learn to put yourself in the driver's seat of your car, so to speak, and have your pain sit beside you or behind you, rather than feeling like your pain is in the driver's seat and it kind of determining everything about your life, about what you can't do, about what you can do, about the nature of your relationships, about how much you can work. A lot of women come to our clinic feeling like just quite overwhelmed and just generally ravaged by their pelvic pain, in the sense that it is completely all-consuming and it has taken control of everything and taken away a lot of the things that they used to enjoy. So my message would be that you can actually claim your life back, but you have to keep an open mind and start looking at a holistic picture, which is what we offer here at the Royal.
I would say that the pain that you're feeling is absolutely valid. And even though I did previously mention that a lot of people do experience pain, your experience of pain must be completely different, and that's still valid as well. In terms of resources, I personally found that the Pelvic Pain Foundation of Australia has very good resources, particularly if you are a parent and trying to find some resources to how to speak to your child about pelvic pain. And especially coming into this role, I found it very useful resource to just be a little bit more educated about women's experiences of that.
I think my message would be to find yourself a good team or a good support system. So whether that's family, a good medical team, just keep searching until you find the people that suit you and that you feel like you are able to place your trust into them and be able to undergo some of the challenges that you face or the things that you want to undertake, similar to what Emily mentioned, the things that you want to get back to in your day-to-day life. I think too many times we hear the narrative of, people seeing multiple healthcare professionals before they come and see us in clinic. And we do have to do a bit of work to create or recreate that trust in the system. But I think don't feel too put down if something doesn't sound right. Just know that you just need to keep being honest with how you're feeling, putting yourself out there to explain your symptoms to the next person that's wanting to help, because that could be the person that could lead you to the right direction.
My message is that change is happening. I think, echoing what's been said, there's a lot of my words are maybe trauma from your experiences with the medical system, or you may have come through many consultations or engagements that were invalidating or felt unheard. But I think there is this generational change, and I think this model before of a more paternalistic style of medicine, but also this model where we're trained to look for causes that you can essentially cut out, or biological-based causes that you can treat that are just very focused to the anatomy, is a different way of thinking. And I think this new way of thinking and trying to put you, as Amy Lee said, in the driver's seat is what we're trying to look at. So push us. So we're trying to change, and I certainly think, I've grown in my practice. I think all of us have grown in our practice because the patients come and they say to us, "What about this?" And I think that we can always do better. The deficiency is sometimes because the person you're seeing may not have the knowledge, rather than the deficiency is that there's no treatments around. Or sometimes it is a mix of treatments rather than just what that one healthcare provider is going to offer. So push us, we are trying, and we're going to keep changing.
I want to thank everyone for coming here tonight. Just a small gift of appreciation for all of you. I also want to take this opportunity to acknowledge and thank the Women's Well who've organised all the food and nibbles outside, as well as Clovelly Community Bank, which helps fund these events so that we can keep these things free. It's also really a wonderful and a big thanks to Amy Donato from the foundation as well for really coordinating tonight. So thank you.